Let me just start with cancer is the leading cause of death in the United States. It's not the first, it's the second after heart disease. Cancer takes years to develop, and we know that. And that, for us, when a cancerous cell or the cancer gets into that cell, it can take up to 40 years before it manifests. And for firefighters, for us, that is extremely important because we have a long latency period for some of the cancers. And when we have that, there's multiple factors. There's multiple factors that you come with, that you're born with, that, some of those things that you can control, smoking, diet. And then there are those environmental factors, the factors that we have every day that we are faced with. Connecting exposure to cancer. So how do we go about that? That's probably the number one issue. Anytime we have a presumption law, we have to go ahead and try to testify, and we do testify, and let those people know that this cancer is coming from our occupation. One area, we're going to have another individual that's going to really delve into this, but it's the International Agency on Research on Cancer, better known as IARC. And it really does look at, these are people that get together and they look at chemicals out there in the world and say, what is the relationship between those chemicals and cancer? And they do that for the general population. We are rolled into that population, but they do that. If it's a group 1, we know that it's a carcinogen. If we know that chemical is a carcinogen, and we know that we're exposed to that carcinogen, we know that we have a relationship there with that. Relevant approaches. You're going to hear, we have some great researchers here. They're going to go over some of the studies here. But a couple of the studies that have taken place, and what we do know, is that animal exposure studies are probably the best that can keep everything the same. That we can do the studies on animals, we can expose them to those chemicals, and then we can study them. That gives us somewhat of a control. But we do know that humans aren't rodents, although that could be debated in here. But we do know that we need epidemiology studies. We know that we need other studies of firefighters out there right now that we are looking at as a cohort, a group of firefighters that we can watch, that we can track, that we can study over time. And that's that cohort study. You're going to hear a lot about that today on a new research taking place and the NIOSH study. Because we really want those similar exposures that firefighters have. And we want to make sure that when we do study firefighters in that cohort group, that we can actually do some case studies we have a group of firefighters that have cancer, and then we can actually look at the population, the general population, and then overlay that with the same age, the same demographics, and saying what are the cancer rates in that population versus what are the cancer rates within the fire service. Some of the biggest studies that we have are called meta-analysis. What's a meta-analysis? What it is, it's taking a group of studies and putting it together. What's the strength of that? The strength of that is, and the problem that we have in the fire service, is that we don't have a high N. We call that the number. Sometimes we don't have women in the fire service or underrepresented. So when we're looking at breast cancer, how many women do we have out there to study? And it's difficult. So if we have individual studies that have some women in those studies and we can combine those, it gives us a strength to make a better definition and definitely a scientific correlation between that cancer and firefighting. So Grace LeMasters really took 32 studies for firefighters, and we're going to have her list here, but she did that and put those together, and you can see that 10 types of cancer that she studied definitely were significantly increased for firefighters. And we had another 10. These are 20 cancers. We had another 10 that were increased, but what we call not significant. NIOSH Firefighter Cancer Study. This is the big daddy, and it's not over. We're still looking at this group, and we're going to be following this group, and you're going to have somebody else talking about this. But it's one of the largest studies in the U.S. on firefighters. 30,000 career firefighters, Chicago, Philly, and San Francisco. 60 years of somebody's life, where we looked from 1950 to 2009. And it was the first study that we could have a group of of those underrepresented in here because it was so large, the 30,000 population. And you got to this study really took a look at two things that really helped us out. The researchers and the principal investigators went back and looked at death certificates and tumor registries. So we're able to go back and take a look at those and add those into the study. We compared those deaths, those diagnoses in the firefighters to the general public. And that's what I had mentioned before on the previous slide. And we tried to control for the age, the sex, the race, and the calendar time. You really want to look at, if you're looking at somebody in the 50s, you have to be very careful about comparing them to somebody in today because of the treatment and some of the cancers that have decreased that were killing us earlier, but we've gotten ahead with the treatment protocols. So the result was we had in that group, in that 30,000, we had 4,461 diagnoses, and we had 3,285 deaths. We had increase in cancer rates overall, both in death and diagnosis. And we had some significant increases for certain cancers that you can see up there. So I kind of want to go through this a little bit, that I want to kind of say, what did the NIOSH study tell us? It was just one study. It was a robust study. It was big, and it brought a lot of information. But what did it actually tell us? We know that every year that we put firefighters on our fallen firefighter memorial, we have a very, very high percentage of those going on the wall. We had almost, out of 249 that we put, 161 are on the wall, that will be on the wall this year in September from occupational cancer. But that's 68, and that's really over 60% every year that we're doing that. That's not the cancer rate that I want to talk about here. What I want to talk about here is that what we have in the general population, this is really what you need to know, from the NIOSH study, we are 14% increase than the general population for cancers. 14%. So you know that. You have those numbers. We already know, even starting off the gates, that this is what we have. And we do know that we have a 9% higher risk in cancer diagnosis. The Firefighter Cancer Support Network that we work with, and they're still here, they have a booth out there, they have a lot of good information for you to go back and take a look at that. So I really ask you to take a look at their website. NIOSH had two parts. First part, we had to go and find how many firefighters died from cancer. We had to find out how many were diagnosed. We had to look at that. The second part of the study was very, very difficult. But the second part is probably the most, the part that you will be interested in the most, because what they had to do is they had to go back, look at those deaths, look at those diagnoses, and then match those with exposure. So you have firefighters out there, and they're going to go back. Now we've got the cancers, we've got the 14% increase, the 9% in diagnosis, we have the numbers. We want to go back now and look at that firefighter. How many runs did that firefighter do? How many calls did they run? How long were they on the fire ground? And how long over a period of time were they firefighters throughout their career? And that really gives you a true indicator of what we're trying to get. And with that, they had lung cancer, you can see, and leukemia risk with that exposure. Those were the two that really that came out. Colon and prostate cancer, this risk here, and you're going to hear me, there's going to be a lot of studies, that was decreased in some of the older population. And what the general president said, and what we're really concerned with, is prostate cancer. We are getting prostate cancer at a higher level at a younger age. Those are when the bells and the lights went off and said that we have to really take a look at this. And that you take a look at this study, and it will spotlight that. And I'll be going over a couple other studies that will kind of bring out what I consider prostate cancer as one of the #1 cancers that we need protection to and more research on. The Nordic study was another study. It was kind of half of what the NIOSH study was, but it really looked at sort of the same parameters, the same group, the same measurement. And I just kind of want to go through a couple of things there that they had an increase. And we had the melanoma, the non-melanoma. We know those are increased, the skin cancer, lung cancer, and then they had an increase in prostate cancer. That's the Nordic study increase. Here's the one that both the Nordic and the NIOSH that we've missed. And we've missed it. Everybody here in the room has missed it. It's mesothelioma. And we do know there's one cancer that I can tell you right now that causes mesothelioma, one particle, and that's asbestos. Asbestos fiber. Sometimes it only takes one fiber in your lung to do that. It can take 40 years for it to manifest. So if it takes that long, going back to those death certificates that we did, that's when we started picking up. Twice the amount in the NIOSH study. But we're retired, we're gone, and we've left the job, and we don't even have the protection for that. And this is something we're going to look at. And this is the one that surprised us. It surprised all of us. The Nordic did it, and we had the NIOSH study did it too. What they said they didn't observe was a change in prostate cancer risk after screening started. So you would imagine that we have the World Fitness Initiative. And one of the biggest things there is the baselines, the medicals, and cancer screening. So you would imagine that if we had these screenings, and we're getting those screenings out there, that we would see a decrease in the prostate that we're getting, and that's not what we're seeing right now. So we're still seeing that increase in prostate cancer. The Australian study is another interesting one. It was 17,000 full-time firefighters, and they had a volunteer cohort in this group also. And some of the things that they brought out in their study, and things that we want to talk about here, is that there was a less risk of lung cancer. And they really attributed that, the researchers, to less smoking. But they had the increase, kidney, prostate, non-Hodgkin's lymphoma. Prostate cancer, again, associated with increased attendance at fires. So again, when I say it was an increased attendance at fires, we go back to the exposures. How many exposures did you have? How many fires did you have? And why it is so important that we have to limit those exposures. I mean, from day one, I think most of us are overexposed at that training academy. I don't know how many went to the training academy, and they would have pit fires, and they would have chemicals being burned, and we were just swallowing all the, from day one, we were getting a dose that we shouldn't have been getting, and that is changing. The one I want to pick out here, the melanoma that we are seeing in firefighters, and the Australian study, we would say, well, it's real sunny out there. They're gonna have a higher melanoma. But what we associated the melanoma in the Australian study was longer service. Again, longer time. The more you're on the job, you're going to get the melanoma. But the thing here is the sunniest places in Australia had the lower melanoma. So it wasn't about just that sun exposure. It was about the other exposures from the job. We have other studies that we're looking at, we're putting in. You'll see it. We have several studies in here, the California Cancer Registry study, a lot. We keep looking at this. At the IAFF, we're looking at all these studies, trying to get information and changing. We have to move forward and change with the new information that we have. You might be hearing a lot from the UK. This is the Institute of Medicine out there. They're doing a meta-analysis. It just came out. What we're always very, very careful with is that this still has to be peer-reviewed. We have to look at this. We're going to consider this very, very closely. Dr. Virginia Weaver, who works with us at Johns Hopkins University, is sort of one of our lead there at the IAFF to kind of go through these studies and guide us through what is actually that we can use and what do we have to wait for to get additional information. Here's just a list. So I went through a lot of studies. I went through them fairly fast, and you have this list. You have down there, and you'll see where the check marks are. And those are the significant cancers that those studies have spotlighted. And if you look at that, and the asterisk there, just to let you know what the asterisk is, that's like an age-specific cancer that they have recognized. So if you look at that, and let's just go down to prostate, you can see from the masters, age-specific in NIOSH, the Nordic, the Australian and California. That's the one. You can see some of those others that we're looking at. We really take a look at this list. There's 10 cancers here that when we go and testify anywhere in the US or Canada, that we can go in there with the information, with the science, and tell those legislators that these are the cancers that are killing firefighters. These are the cancers that we have to have protection. And just remember, no information is stagnant. No studies are stagnant. We're going to continue to add information in to make sure that we're getting the best information to the firefighters. Challenges for our studies in the firefighter population is exposure miscalculation. The healthy worker effect. I'll spend just a minute on this. What is the healthy worker effect? So if you're a researcher, you're going to study cancer. You're going to study cancer in the general population. You want the old, you want the young, you want the healthy, you want the sick, but you want them all in that that population when you're studying it, because that's the slice of the population that you need to get the information. For firefighters, if you look at our group, and if you were to do the same thing and say, we're going to study a cohort of firefighters just in one group, we have to take into account that we are healthier than the general population. If we have a reduced risk in some of these cancers, but if you look at our healthy population, we have to add back in that we are firefighters, we're coming, we are more physically fit. We have additional screening responsibilities. We have this candidate physical abilities test that you have to take. So our population, and you start squeezing it together, is extremely healthy. So we always have to take a look at that for adjusting those studies. This one here is just, we have to make sure that some of the data that we have, did we have all the data? Did we have the history? Did we have the diet? Did we have the weight? Do we have other exposures? We can't kid ourselves. We can't kid ourselves and say that there are other factors, that can contribute to this, along with our exposures. And we really have to take a look. So, significant size of effect, size here is that, tobacco smoke. If you take tobacco smoke right now, what that's saying right there is that if you're living with someone who's smoking cigarettes, you have 1.25 chance of getting cancer just from the secondary smoke. Move that out to what we do. We have secondary smoke on every single call that we run with fire. There is some good news. There's been a drop in death for the general population. We have fewer, 26% from 1991. That's great because of the treatment and what we're seeing, that we can get ahead of the cancers and save lives. So we have a reduction. It still remains the second leading cause of death with over 600,000 deaths for the general population. And this is the one that scares me the most. This is the one sometimes I don't understand it. I got to delve into it. I have to ask the people that really understand it. Is that when you start to see a chart that says the general population of cancers are starting to go down, but then you start to see a rise in the firefighter population in certain areas going up, that's when we know we have a significant problem. We got to talk about it. These are things that we have to do. The general president said the Wellness Fitness Initiative. And when we started that in 1996 and 97, when we were really down, and the general president chaired that group, we said one of the first things we said, we have to have firefighters stop smoking. We had to have them to quit smoking. We said, let's get policies in there and say that if you're going to hire fire, maybe you have to grandfather it in. But we said that would be one of the #1 areas that we could start to reduce cancers. And that was really, really important for us to put that in there. But we have those things that we do know that these decreases. We're starting to see a decrease in cigarette smoking. The only thing that we're worried about the firefighters with cigarette smoking is now they're doing smokeless tobacco. And we're starting to see an increase in some other cancers. So we really have to take a look. When you look at cancer, you're coming in, and we know the risks are high to do the job that we do. Can you counter those risks? Can you put those fitness programs together? Can you put an annual, if you don't have an annual medical in your fire department, you've got to go back and have those baselines. You have to have that on a yearly basis. The only way that we can catch this cancers early is with those early screenings. But you have these other elements that you have to put in there on this, and we have to do that. We know that the second leading cause right now in cancer in the general population they're contributing is obesity. We have to start taking a look at this and putting this into play. We've selected other types of risk factors. You said some of the cancers that come from this. We know that this is here from obesity, alcohol, and smokeless tobacco. Those are the cancers that are coming from that exposure. Unvalidated cancer screening tests. I'm not going to spend a lot of time on this, but we are really concerned. We have a lot of people out there saying this is the latest screening panel that I have. This is the latest screening that is going to find cancers in your whole population. We take this very, very serious. We make sure that we don't just take somebody's test and say that that's what we're going to do, screening tests. We are looking at these, and sometimes we have to put out paper that we do not have enough evidence that this is actually taking place. So I know we have a lot of people out there that have this. Well, we have position papers on this, but we're going to continue to look at this and make sure that we're researching this. So if someone is getting a screening, it's for the right reason. It's not just that somebody wants to make an awful lot of money screening every firefighter for certain things. We want to make sure we're doing it for the right reason. We do recommend that we reduce the occupational exposure, the non-occupational exposures. I've talked about that. We talked about the Wellness Fitness Initiative. Cancer screening tests are built into that. NFPA 1500 has it in there. And I really, really challenge you, take the cancer awareness course on our site. It's an online course. Sometimes you think you have all the information, sometimes you know it. Go back, put it out, make sure it's a membership, tell the department, let's just do this as an in-service drill. You really need to do that.